Hey, good morning and welcome to Euronurse. I'm your host, Vic Senese. Welcome to the show and, like and subscribe. Hey, today we got a great show for you. We're going to be taking, today's, we're going to be having a one contact hour video program that will provide a thorough update on how the treatment paradigm for advanced renal cell carcinoma has evolved rapidly in recent years with the arrival of next generation tyrokinase inhibitors and combination approaches with immune checkpoint inhibitors. So we're going to welcome Dr. Eric Jonasch from the University of Texas MD Anderson to the show. But remember now, to get your one contact hour, some people have had some questions about that. So I got a little video here together. I'm going to show you real quick here on how you manage to get that one contact hour. Hang on one second. Here we go. So go to the website, euronurse.com, and then you'll find a box that'll have this one ANCC contact hour. Just click that. It's going to bring you over to the My CME program. You'll have to look through and then just kind of fast forward through the movies, because I put these all together to make it more cohesive and easier to watch. And in order to get to the test, you got to go through them. You'll have to answer some questions in between as we get to these things here, as going through them. So really quick, you go through, you get to the next box, and then eventually you're going to get to the final one. Like I said, it was broken up into lots of little pieces. This, I think, is the last one. And that'll bring you, and you answer those questions as you're going through. That'll bring you to the post-assessment box, and then you click on that. And then once you get to there, you'll take your assessment test. It'll show you how to get your CE real easily. So hope you enjoy this program, and I'll talk to you when we finish up for some information about what's coming up next week. So let's get rolling right now.
I'm Dr. Eric Jonasch. I'm professor of medicine at UT-MD Anderson Cancer Center. And today we're going to talk about optimizing care of veterans with advanced renal cell carcinoma, maximizing the potential of immunotherapy and targeted agents. At the conclusion of this activity, participants should be able to compare and contrast the efficacy and safety of first-line immunotherapy and immunotherapy targeted therapy combination regimens for advanced renal cell carcinoma. They should be able to assess the clinical benefit of emerging treatment options for patients with advanced renal cell carcinoma who have progressed on prior immunotherapy and/or targeted therapy. They should be able to integrate clinically beneficial therapeutic approaches into treatment plans for patients with advanced renal cell carcinomas within the Veterans Health Administration healthcare system. And they should differentiate between adverse events associated with immunotherapy and targeted therapy and create tailored management approaches that are appropriate for patients with advanced renal cell carcinomas within the VHA healthcare system. All right, so let's start now with incidence rates and risk factors of renal cell carcinoma among veterans. This disease seems to be increasing across the population and also seems to be increasing in the military population. We don't fully understand why this increase is occurring, but there are some veteran-specific risk factors that include high exposure to occupational hazards, tobacco and alcohol use, obesity, and other high comorbidity burdens. There are some oncology program resources available that are on the VA NOP website, and you can see them here. The Clinical Oncology Pathways U.S. Department of Veteran Affairs has a number of diseases that may be caused by military service or are assumed to be caused by military service. And this is because of the unique circumstances of veterans' military service. And if it's diagnosed in a veteran within a certain group, they can be awarded disability compensation. And renal cell carcinoma is included in this designation. Here's the pathway that's in the VA system. You can see here, individuals with stage 4 relapsed clear cell renal cell carcinoma should undergo multidisciplinary discussion. If they're a candidate for cytoreductive nephrectomy, that intervention can be performed. If it doesn't seem to be appropriate, the question then is, are they intermediate or poor risk? If they are, then you will think about either pembrolizumab and axitinib or ipilimumab nivolumab. If they are not poor risk, you would think of pembrolizumab and axitinib. And if they progress after first-line therapy, cabozantinib is the favored choice. Obviously, there is a number of other options and a number of other different ways of looking at this, but this is the pathway that's available through the VA Oncology Clinical Pathways resource. So let's talk about risk stratification and molecular characterization. The images on the left are from a paper that was originally published in the early 2000s. And here we have clear cell, papillary, used to be called papillary type 1 and papillary type 2, and chromophobe renal cell carcinoma. Now we don't designate papillary as type 1 or type 2 because there's actually a number of different papillary subtypes. Low grade or high grade probably be more appropriate. And what this also shows is that there are some germline mutations that are associated with syndromes that include some of these cancer types. VHL disease is strongly associated with multifocal bilateral renal cell carcinomas of clear cell histology. Hereditary papillary renal cell carcinoma syndrome is associated with tumors that have papillary histology and is associated with a germline mutation in the MET gene. Individuals who have HLRCC will have a germline mutation in the fumarate hydratase or FH gene and will develop high-grade solitary papillary renal cell carcinomas that can grow very rapidly. And individuals with Birt-Hogg-Dubé will have germline mutations in folliculin, and amongst other tumors in their kidneys, they can develop chromophobe renal cell carcinoma. What I have on the right is the WHO classification for renal cell carcinomas. And we can see here now there's quite a few subtypes. And these are broken into clear cell, papillary, collecting duct, other, and also now molecularly defined renal cell carcinomas. The renal cell carcinoma is a little bit behind other diseases like lung cancer and breast cancer in terms of molecular subclassification. In 2025, these molecular subclassifications aren't necessarily associated with specific therapy types. I'm hoping that's going to change in the next 5 to 10 years. But you can see here, for example, on the bottom right, we have the TFA3 and TFAB translocation renal cell carcinomas. We have, as mentioned before, the FH or fumarate hydratase deficient renal cell carcinomas, succinate dehydrogenase deficient renal cell carcinomas, ALK rearranged, and also SMARCB1 deficient. And these are often medullary renal cell carcinomas. Our particular interest in the military population. This often occurs in individuals with sickle cell trait, often African American, and in athletes because the high exercise load can be associated with some hypoxia, particularly in the right kidney. For advanced renal cell carcinoma, we have several prognostic models. The oldest is the MSKCC prognostic model. We have 5 features that we can see in the box. And if you have none of these features in individuals who received interferon, they had the best survival. And then you can see that the survival goes down as a function of an increasing number of these, with poorest individuals having 3 or more of these risk factors. The IMDC criteria are pretty similar to the MSKCC, but this model was trained on individuals receiving TKIs in the late 2000s. And we can see here a nice separation between favorable, intermediate, and poor risk. And in 2025, this is still probably biologically relevant and important. We know that those individuals with favorable risk behave differently than those with intermediate and poor risk. But as we're going to see in a couple of slides, the treatment doesn't seem to be that different at this point in time, although that may change. There are a couple of criteria for therapy decisions that go beyond tumor biology. The age of the patient, their occupation. Socioeconomic status, I don't like that one, but still it certainly has an impact in terms of whether or not individuals are able to travel, are able to spend time in a particular area. Access to specialized cancer centers is obviously important, and is linked to the third one. Comorbidities, in particular autoimmune diseases, are things to think about because they can be a contraindication to immune therapy. Their overall life expectancy, and the patient preferences. What are the goals of the patient's care, and what do they really want out of their treatment journey? So let's now move on to first-line systemic therapy for metastatic renal cell carcinoma. Here are the NCCN guidelines. This is the version 3, 2025. There is a slightly newer version. It hasn't really changed that much, but we can see here that in first-line therapy for clear cell histology, it's divided by favorable and intermediate/poor. And we can see that the preferred regimens are pretty similar. We have axitinib pembrolizumab, cabozantinib nivolumab, lenvatinib pembrolizumab, and ipilimumab nivolumab. And the only difference in the intermediate poor is we also have single-agent cabozantinib. The reason it's not preferred in the favorable risk is that the study that looked at cabozantinib versus sunitinib in the frontline setting enrolled only intermediate poor risk patients. So let's look at some of the studies that have resulted in this set of recommendations. First, Checkmate 214 looked at the combination of ipilimumab and nivolumab versus sunitinib with the primary endpoint of objective response rate, OS, and PFS in intermediate poor risk patients who were treatment naive, had advanced clear cell renal cell carcinoma, measurable disease, reasonable performance status. And these eligibility criteria that we see in this box on the left are pretty similar for the other three studies that I'm going to be talking about after this one. In terms of the baseline characteristics, again, these are pretty similar across these trials. Older males. And in this study, about a quarter of the patients had favorable risk features. And what we see with long-term overall survival is that this study remains positive. And this study has been looked at the longest of all in terms of follow-up, and there's been 9-year follow-up here. And we can see in the intent to treat OS curves on the left that there's a separation that is persistent. This is true in the intermediate and poor risk group. And we can see that in the favorable risk group, there's also the beginning of a separation of the curves here as well, although that didn't happen until after about 5 years or so. So there's a subgroup of individuals who do remain alive in the ipi-nivo group, and there's a fewer number of these individuals that are long-term survival in the favorable. But if you look at the integral, if you will, of the curve, the hazard ratio, it's not statistically significantly different. For progression-free survival in the intermediate poor risk group on the left, we see that there's that separation of the curve, and then there's a plateauing of that PFS curve for ipilimumab, nivolumab, whereas the plateau with sunitinib is considerably lower. And with favorable risk, initially, the PFS for sunitinib was superior to ipilimumab and nivolumab, but with long-term follow-up, we see eventual collapsing of those curves. So it's clearly a larger number of people who remain disease-free for longer with sunitinib, but eventually those individuals will progress, and there's a bit of a tail, I guess, in both, although there's very few patients still on study at that point in time. In terms of objective response rates, they're low-ish compared to the TKIs. We see that by RECIST for ipilimumab, nivolumab in the ITT population is a 39% objective response rate versus 33%. 33 pretty high for sunitinib in this group, which is predominantly intermediate poor risk. We see that for favorable risk for sunitinib, 52% objective response rate versus 30% for ipilimumab, nivolumab. What's not on here is progressive disease as best response, which is 18% for ipilimumab, nivolumab. And that's an important number to remember as we look at that number for other clinical trials. One of the other questions is, are there organ sites of metastasis that will actually predict for whether or not a particular regimen is useful? And here we can see lung, liver, and bone metastases. I'll draw your attention to the hazard ratios for progression-free survival. The second from bottom row, we see that for lung, the hazard ratio is 0.77 in favor, obviously, of ipi-nivo, which is statistically significant. Obviously, these trials are not powered for this, and you can see there's a fairly large number there. But then for liver, where we have 99 versus 107 patients, we see the hazard ratio is creeping up, and there's a wide confidence interval, and this is not statistically significant. And then for bone on the right, again, similar numbers of patients, we can see the hazard ratio there was 1.07, wide confidence intervals. And this is something I see in practice as well. Individuals who have extensive liver or extensive bone metastases tend not to respond as well to ipilimumab and nivolumab. One of the calling cards, as we've alluded to, is this durability of response. And there's also a subset of individuals who can stay off treatment for a period of time. Here we have on the left swimmer's plot showing 59 of the complete responders. And we can see in the middle there where the orangey line turns to blue, these are individuals who were on treatment, got off treatment, and did not have to get back onto treatment. So they have a treatment-free interval, which is obviously a very attractive thing for patients. Oncologists love combining things. And so this study, which looked at induction of ipilimumab, nivolumab, then randomized individuals who had stable disease between continuation of nivolumab versus the addition of cabozantinib to nivolumab. The study is underway. It's going to take probably a couple of years for us to get the final results in this trial. But what was interesting about the initial preliminary analysis or preliminary reports on this was about a third of the patients actually came off study, the first imaging study. So this would suggest that Ipi-Nivo in the community is slightly more challenging to give. Moving on to the IOTKIs. The first one, Keynote 426, looking at axitinib and pembrolizumab. Very similar eligibility criteria. The primary endpoints here, OS and PFS, but in all patients, not just the intermediate and poor risk group. Pembrolizumab plus axitinib versus sunitinib. The first interim analysis, the OS hazard ratio is 0.53, so stunningly low in favor of the combination. But what we've seen over time is that the benefit or the difference between these doublets versus sunitinib does tend to diminish over time for reasons that are not entirely clear. What we have here now in the favorable risk group, the left, the OS curves, we see that they're overlapping, so no statistically significant difference there. Same as with ipilimumab and nivolumab. PFS, we see a separation of the curves, not statistically significantly different in terms of the 95% confidence intervals, but I know which curve I'd want to be on here. On the right, we have the objective response rate, 69% versus 50%. Again, favorable risk group. And we can see the CR rate of 13 versus 6% and a very low PD as best response rate. So pretty good numbers here in the favorable risk group, although no OS advantage. In their intermediate and poor risk group, OS curves are separated. They start coming together here towards 6 years. The hazard ratio is still in favor of pembrolizumab axitinib. Progression-free survival curves, separation of the curves, nice persistence of that separation, good hazard ratio, and the 95% confidence interval is not overlapping 1. In terms of objective response rates here in this higher risk group, 57% versus 35%. CR is 11 versus 3. And then the PD rate here in this intermediate poor risk group, 15% for pembrolizumab axitinib. So somewhat higher than in the favorable risk group, but still lower than what we saw with ipilimumab nivolumab. Moving on to the next doublet here, we've got Checkmate 9ER. This is a phase 3 randomized study of nivolumab and cabozantinib versus sunitinib. Very similar eligibility criteria. The primary endpoint here was PFS. And what we saw in this study was that in the favorable risk population, we've got now the PFS curves on the left, separation of the curves, hazard ratio of 0.67. OS, no difference. So 3 out of 3 now, where there was no OS advantage in the favorable risk group. In terms of objective response rates on the right, we can see that there's a high CR rate with Nivo-Cabo, very low PD as best response in this favorable risk group, an objective response rate of 66 versus 43%. One of the other things here to see is that the objective response rates are different in these different studies. It just shows that patient populations vary a little bit from trial to trial. In the intermediate and poor risk group here, we have progression-free survival on the left, statistically significantly different with a hazard ratio of 0.56, and the OS 0.74, statistically significant. Objective response rate in this higher risk group of 53% versus 23%, and the PD as best response 7.6 versus 17%. So a pretty low PD as best response even in this high risk group. What about organ metastases and response? Here we look at liver, bone, and lung, very similar to Checkmate 214. Let's focus on the PFS, 0.55 for liver, 0.43 for bone, and 0.56 for lung. So at least from a PFS perspective, and as you look below from an OS perspective, definitely the doublet is doing better in these high-risk groups, liver and bone, compared to, for example, Checkmate 214. Last of these doublets, the CLEAR study looked at lenvatinib plus pembrolizumab versus sunitinib. There was a lenvatinib everolimus arm as well, which did not meet its primary endpoints. Very similar eligibility criteria. Again here, just as a reminder, advanced clear cell renal cell carcinoma treatment naive. Primary endpoint of PFS with the secondary endpoints of the usual expected ones. Here we saw a PFS of 24 months compared to 9.2 months for sunitinib. We saw an objective response rate of 71% versus 37%, and a PD as best response of around 5%. But the overall survival is seen numerically not difference, although the shape of the curves results in a hazard ratio of 0.79. What happens is these curves come together at 50 or 60 months, but they stay apart until then, resulting in a better hazard ratio or hazard ratio in favor of the doublet. can see some of the shape of these curves here. So favorable risk, once again, there's no OS survival, 4 out of 4. In intermediate and poor risk group, we see the separation of the curves and them coming together for reasons that are not entirely clear. But clearly, there's a larger number of people alive over time if they receive lenpembro versus sunitinib. In the progression-free survival curves, wide separation. We can see here definitely better for lenpembro compared to sunitinib, whether this is favorable on the left or intermediate poor on the right. There's a little bit of a disconnect between these PFS curves and the OS curves, and we don't have a clear explanation as to why. What we do have is clear evidence that if individuals have bone, CNS, renal, liver, lung, or lymph node subsites of metastases, the hazard ratios are in favor of the lenvatinib pembrolizumab combination over sunitinib in each of these categories, with hazard ratios of 0.4 for bone, 0.47 for CNS, 0.65 for kidney, 0.52 for liver, 0.48 for lung, and 0.63 for lymph nodes. So very strongly in favor of the doublet. Once again, favorable risk populations, no OS survival in any of these groups. And then a couple of sort of cross-trial comparisons. We can see the hazard ratio for overall survival in each of these is positive. You can see it varies between 0.72 and 0.84, but all statistically significant. And also primary PD. So if you start a patient on therapy, what's the likelihood at the first scan that they've progressed? See, this is highest for CheckMate 214, 18%. And you can see for Cabo-Nivo, 6%, Len-Pem, 5%, and for Axi-Pembro, 11%. There's a number of ongoing trials asking various questions. For example, should we be doing cytoreductive nephrectomy in the IO era? The PROBE study will be asking that question. We mentioned the Pedigree study, whether or not we should be adding Cabo to patients with stable disease on nivolumab after ipi-nivo induction. SBRT, stereotactic body radiosurgery, is becoming increasingly used in patients with advanced renal cell carcinoma, and the Samurai study is looking at whether or not we should be adding this in. Belzutifan, which we're going to be talking about some more, is being looked at in combination in the frontline setting in LIGHTSPARK-12, together with TKIs in LIGHTSPARK-3. And then the Cosmic 313 study was a study that looked at adding cabozantinib to ipilimumab nivolumab, although the PFS was slightly higher in the experimental arm, the toxicities were unfavorable, and the overall survival was not different. So in summary for frontline therapy, are combination regimens better? Well, we do see from a perspective of OS, all of the studies were statistically significantly better with the doublet compared to sunitinib. We did see that there is higher objective response rates in general, higher progression-free survivals in the combination arms compared to sunitinib. We see some interesting variations here, for example, for ipilimumab in the favorable risk group. The PFS is shorter, but the objective response rates are lower. But there's a subset of individuals, and I didn't actually show those numbers, 13% of patients with ipi-nivo in the favorable risk group had a CR compared to 6% with sunitinib. If you do get a response, the response is more durable, even in the favorable risk group. For the IO-TKI combinations, all of them show OS, PFS, and objective response rate advantage over sunitinib. In the favorable risk group, things start getting a bit more complicated. No OS advantage, but definitely PFS and objective response rate advantages. So let's talk now about Mrs. Williamson. She's a 65-year-old female presenting with a persistent cough. Imaging shows extensive mediastinal adenopathy with narrowing of the left mainstem bronchus, a large left renal mass, and a few small bone lesions. And biopsy reveals clear cell renal cell carcinoma. So what would you do for this patient? Would you give her ipilimumab plus nivolumab? Would you give her lenvatinib plus pembrolizumab, cabozantinib plus nivolumab, or axitinib plus pembrolizumab? There's E, which would be any IO-TKI would be good here, or F, where either Cabo-Nivo or Axi-Pembro are the best. So my answer here would be, especially in the VA environment, B, C, or D. An IO-TKI here would be better because you have a higher probability of an objective response. She's in trouble. If this continues to progress in the lungs, she may end up blocking off one of her mainstem bronchi. You need a response sooner rather than later. If she didn't have that threatening disease Ipi-Nivo would be my go-to choice because of the fact that there's a possibility of having long-term durable response, which is likely higher with Ipi-Nivo compared to any of the IO-TKI doublets. So let's now move on to subsequent line therapy. Once again, the NCCN guidelines, recent version, couple of things here. One, this is divided into IO therapy naive, which is becoming an increasingly less common group of patients, and patients who have received prior IO therapy. We don't have any preferred regimens for either because of the fact that the frontline setting has moved on so quickly. We haven't really managed to catch up, and we haven't had any blockbuster findings in the second or third line setting that give us a preferred regimen. But what we do have in the IO therapy naive is, I would call, eminence-based advice that if a patient has not seen IO therapy before, they should probably be challenged with IO therapy. Very few individuals like this still. Somebody's been on sunitinib for years and then progresses. You should try them on an IO-based regimen. Do we have a ton of data showing that this would be useful? With ipilimumab, nivolumab, most of those individuals in the phase 1 study obviously had received prior TKIs, so we do know that works. And IO TKIs probably are reasonable choices as well. Now, for those who've received prior IO therapy, we see here that we have single-agent axitinib, belzutifan, cabozantinib, lenvatinib plus everolimus, and tivozanib. And why are they in this order? Because it's alphabetical. So let's talk about some of these and talk about some of the background data. One of the things you may notice here is there's no IO TKI for individuals who have received prior IO therapy. And we now have data to support that. So in the post-TKI era, axitinib, nivolumab, cabozantinib, and lenvatinib everolimus had large randomized registrational studies that resulted in their approval. Nivolumab, cabozantinib, and lenvatinib everolimus all had improved overall survival compared to everolimus monotherapy. Axitinib did not over sorafenib, although the PFS was better. In TiVo-3, tivozanib was evaluated in the third-line setting against sorafenib in patients with advanced renal cell carcinoma. We see the Kaplan-Meier progression-free survival curves on the left with a hazard ratio of 0.624. And in terms of subgroup analysis, just draw your attention to the fact that it looks like the favorable risk group ended up having the greatest delta of benefit for tivozanib over sorafenib. Moving on now to the latest kid on the block, belzutifan, originally called PT2977. And how does this drug work? Well, as mentioned before, most clear cell renal cell carcinomas, whether it's in the sporadic setting or in the hereditary setting, will have a mutation in the tumor of VHL. VHL is an E3 ubiquitin ligase that will take prolyl hydroxylated HIF2 alpha and degrade it in the proteasome. Under hypoxic conditions, you do not get prolyl hydroxylation of HIF2 alpha. You will not get activation of this. You will not get heterodimerization. You will get heterodimerization of HIF2 alpha with HIF1 beta, and you will get transcription of pro-survival, pro-metastasis, pro-angiogenic, and pro-proliferative genes. If you have normoxia, we don't have this happen. If you have hypoxia, we do have this happen. If you have damaged VHL, you do have this happen. So it makes sense that if you have broken VHL, blocking this excess HIF2 alpha mediated transcription would be a good thing. Belzutifan binds to a cleft in the HIF2 alpha pass B domain, prevents heterodimerization with HIF1 beta, and basically decreases the transcription of these various signals that favor the tumor cell. There is a phase 1b/2 study that we published now 4 years ago, showing in individuals who had a median of 3 prior lines of therapy, there was an objective response rate of 25%, disease control rate of 80%, and a progression-free survival of 14.5 months. LIGHTSPARK 005 was the randomized registrational study comparing belzutifan to everolimus with a primary endpoint of PFS and OS. It met its primary PFS endpoint, but you can see that the curves only separate at the median. So although the median wasn't any different, the hazard ratio in favor of belzutifan was 0.75. OS, there is a slight separation of the curves, but this is not statistically significant, a p-value of 0.18. And the objective response rates are around 22 to 23% for belzutifan versus 3.5% for everolimus. And you can see there that the PD as best response with belzutifan is 34%. And this is the biggest sort of Achilles heel of this drug, that about a third of individuals in the refractory setting don't respond. But those who do have durable response. The duration of response in individuals who did receive this drug is close to 2 years. Adverse events for this drug are a little bit different. Because EPO is a HIF2 alpha client gene, we do see anemia being the most common side effect, and we also see hypoxia. Mechanism is a little unclear. It might be some sort of a VQ mismatch that's induced pharmacologically, or carotid body dysfunction resulting in hypopnea. But about 10% of individuals will have a drop in their oxygen saturation below 90%. In my practice, the half-life of this drug is 14 hours. We hold the drug, we wait for the oxygen level to go up, and then we decrease the dose. Some people give oxygen. That I think might be a little bit excessive. For the anemia, in my practice, we give ESAs. So because of the rapid advance of the frontline setting where the large majority of individuals receive IO, the question of whether TKIs are useful in the post-IO setting was first answered with small prospective and retrospective studies. And we see here that with a small prospective axitinib study, a retrospective experience of various agents at Memorial Sloan Kettering and MD Anderson, some real-world pazopanib data, a phase 2 sunitinib study, a phase 2 pazopanib study, and some retrospective analyses of lenvatinib and everolimus, that PFSs are in the 5 to 13-month range, so really not bad, suggesting that giving TKIs post-IO might be a useful thing to do. This non-randomized study, looking at the combination of lenvatinib and pembrolizumab post-IO, and these individuals, a third of them had received ipilimumab, nivolumab, all of them had received some sort of prior IO therapy, had a primary endpoint of objective response rate at 24 weeks. It showed an objective response rate overall of around 57%. It showed PFS of close to a year. So just looking at this study in isolation, one would think that maybe we should be continuing IO and adding TKI post-IO. But we now have 2 randomized studies that disabuse us of that concept. So Contact 3 randomized individuals who had received prior IO therapy as their most recent line of treatment between cabozantinib plus atezolizumab and compared it to cabozantinib with the primary endpoints of PFS and OS. There was no statistically significant difference between the 2 arms. We can see here the Kaplan-Meier curves. And one of the other things that's really important here is that the PFS for cabo monotherapy was 10.8 months. So it's pretty good. And we have several other studies now that show that that's probably around where we are landing with cabozantinib post-IO. Now we have TiNivo-2, which is a randomized study of tivozanib plus nivolumab versus tivozanib for individuals who had received prior therapy with IO. In this study, there's a slight difference, is that you didn't have to have received prior IO as your most recent line of therapy. And this study randomized individuals between tivozanib and nivolumab versus tivozanib. Note that the tivozanib dose in the doublet arm is slightly lower per the FDA, and the primary endpoint was progression-free survival. Baseline demographics, very typical for this population, older, predominantly male. No difference in progression-free survival. We see here the orange TiNivo line actually kind of lagging slightly below the tivozanib line with a 7.4 versus 5.7 month median progression-free survival. If patients were strictly second line, we see here, once again, no difference in the PFS for tivozanib, kind of approaching that of what we saw with cabozantinib of 9.2 months. In third line setting, once again, no difference here in the progression-free survival. If immune checkpoint inhibition was the most recent therapy, once again, no difference. And if a non-immune checkpoint inhibitor was the most recent therapy, once again, no difference. So now we have 2 studies, large enough, randomized, showing that adding IO to TKI post-IO, for whatever reason, does not seem to be associated with a better progression-free survival. There are a number of ongoing studies asking a variety of different questions. First of all, should we be adding a TKI to belzutifan? And this study had 2 cohorts, a treatment-naive cohort and a prior immunotherapy-treated plus targeted therapy-treated group. The group that received prior IO and TKI had a PFS of around 13.5 months. The group 1, which was treatment naive, was predominantly favorable risk and had a PFS of 30 months and an objective response rate of 70%. So very provocative and raises the question of whether we should be moving belzutifan further up in our treatment algorithms. This study looked at belzutifan plus lenvatinib versus cabozantinib with primary endpoints of PFS and OS, LightSpark 11. This completed accrual quite some time ago. As you can see, the N is quite large, and we're anxiously awaiting the results. So for patients who have received prior IO therapy, seeking second-line therapy, TKIs are probably the most appropriate. For individuals who are IO naive, although we lack data, I think it makes sense to challenge them with an IO-containing doublet. In third line, based on registrational data, belzutifan and tivozanib have demonstrated superiority over their comparators. And we clearly need more data in this space. So let's move on to our second case, Mr. Johnson. He's a 63-year-old male diagnosed with metastatic clear cell renal cell carcinoma after presenting with gross hematuria. He's found to have pulmonary lesions and mediastinal adenopathy. He undergoes biopsy, revealing clear cell renal cell carcinoma. He receives ipilimumab, nivolumab. He gets stable disease, but unfortunately, after about a year, starts developing progressive disease and a small bone lesion. So for this patient, what would you do? Would you give him cabozantinib? Would you give him cabo-nivo? Do you give him lenva-pembro? Are either B or C good choices, or none of the above? So based on the data that I showed, cabozantinib here I think would be a very good choice. A PFS likely in the 10-month range, reasonable objective response rates, a reasonable tolerability. We have good data now suggesting that continuing checkpoint blockade is not helpful. He starts on cabozantinib. He develops diarrhea and hand-foot syndrome, and dose reduces to 40 milligrams by mouth per day with good quality of life. Gets a partial response. After a bit more than a year, new lesions arise in the lungs and mediastinum. At this point in time, how would you treat this patient? Would you give him A, tivozanib, B, belzutifan, C, everolimus? Choice D, tivozanib or belzutifan. Choice E, A and C, tivozanib or everolimus. So in this situation, I think both tivozanib and belzutifan are reasonable options. Really depends on how the patient has done with regards to TKI side effects, whether they would like to have a slightly different MOA and availability. Lastly, let's talk about toxicity management. So there are a number of adverse events associated with TKIs. The cardiovascular AEs can be venous and potentially arterial thromboses, high blood pressure, heart failure, basically decreased contractility, QT prolongation, rarely torsades. We also see the non-cardiovascular AEs like diarrhea, nausea, vomiting, fatigue, hand-foot syndrome, loss of taste. And the way we manage these is we usually have the patients take breaks, which often helps them. We need to dose reduce or a combination thereof. IO-based therapy induce what I would call the itises. We get inflammatory changes that can be in the brain, can be in the lungs, in the liver, in the kidneys, in the adrenal glands, in the thyroid, in the joints. There's a number of different algorithms to sort of specify workups by organ or system type. It's true that for the IO-TKI combinations as well as for the IO-IO combinations, that a number of these are prevalent. I don't think the tables speak to what we commonly see. For ipilimumab, nivolumab, it's the colitis, the hypophysitis, the adrenal insufficiency, the myocarditis, the myositis that really are the things that we watch for and are most concerned about. For the IO-TKIs, it's going to be the transaminitis, the diarrhea that are generally the most common issues that we see. There's a discordance between the frequency and the lethality of these IRAEs, thankfully. So we can see here that colitis is the most common, but it's one of the least morbid. Myocarditis, on the other hand, is relatively rare, but has a very high fatality rate. Part of this is because of the severity of the symptoms. It's also partly because we as practitioners have issues sometimes in identifying them and managing them and intervening in an appropriate manner. Another thing that is interesting is that it looks like IRAEs if they do happen, although we obviously need to manage and control them, are associated probably with longer survival, maybe due to the fact that those individuals have a more active immune system. So although we don't celebrate when we see these side effects, we can be reassured by the fact that it might be associated with better long-term outcome, provided we manage the toxicities appropriately. In general, if you have a grade 1 to 2 toxicity and you're thinking about it being perhaps IO or TKI related, holding the TKI if the patient's on an IO TKI, maybe skipping a dose of nivolumab if the patient is on nivolumab is a reasonable thing to do here. Sometimes you might need steroids if patients, for example, have joint symptoms and things like that. But it's the grade 3 to 4 where you're going to be holding. The patients might require hospitalization. If you're quite concerned it's an IRA, they might require high-dose steroids, and you might need to start consulting specialists, for example, in cardiac or lung or kidney or GI. So let's talk about Ms. Holloway. She's a 47-year-old female who started on ipilimumab plus nivolumab. 5 weeks into treatment, she develops worsening fatigue, malaise, and starts feeling a little bit lightheaded on standing. Clinical evaluation reveals a blood pressure of 85/58 and a regular heart rate. So what would you do for this patient? We have choice A, assessing serum cortisol, ACTH, LH, FSH, prolactin, TSH, and GH, essentially posterior pituitary hormones. B, order a brain MRI to assess the posterior pituitary. C, empirically administer stress dose steroids. D would be all of the above. E would be all of those, but not order the brain MRI. In our practice, we would be doing all of the above. We would be essentially assessing functional posterior pituitary function. The brain MRI demonstrates the presence or absence of inflammation versus some other mass effect on the posterior pituitary, and administering stress dose steroids. One could make an argument that the brain MRI is not absolutely necessary here because you've identified the functional defect, but perhaps knowing that this is not due to some sort of a tumor in that area may be helpful. So in summary, risk stratification and other patient and disease-specific factors should be used to individualize therapies for patients with advanced or metastatic renal cell carcinoma. We didn't really talk about non-clear cell renal cell carcinomas, but looking at histology, looking at risk stratification, looking at the comorbidities, and finding out what the patient preferences are really important to help make the best choice, especially in the frontline setting. Selecting optimal first-line therapy for individual patients is important. Integrate the information on the sites of disease, patient condition, risk stratification, and patient preferences to make those choices. In the second and later line treatment, we should not continue IO based on our current evidence, but there's a number of different options that are definitely helpful that can prolong progression-free survival, can prolong overall survival, and improve the quality of life of our patients. And we should monitor and mitigate adverse events associated with IO-based combination strategies, recognizing that similar toxicities might be caused by different things. We didn't talk about it, but for example, if the patient develops diarrhea and it's gradually increasing diarrhea and they're on IO TKI, maybe holding the TKI for a couple of days and seeing whether or not that helps is a reasonable first step as opposed to stopping everything. So I'd like to end there. Thank you so much for your attention. I hope this was helpful, and good luck with your treatment of patients with advanced renal cell carcinoma.
Well, there you go. So that was pretty interesting. For those of you that have been out there and in practice as long as I have, interesting. There wasn't really much you could give patients outside of a radical nephrectomy for treating renal cell carcinoma. If you got it early enough, they were cured. If you didn't, they probably didn't survive. A lot of promise with these new drugs. So I thought this would be a good one to focus on for today. So again, remember to go into the website, euronurse.com. It will be moved down after the show finishes. It'll actually go into the past episodes. So you'll see it down on the bottom of the past episodes, or down lower in the course, because the newest episode will be up on the top. But anyway, that box will still be there, the yellow box. Click it, like I gave you that little preview on how to get through to take the test. In Illinois, our licenses renew this May, I believe. So you always need to have those contact hours to renew your license. So I'm getting ready to renew mine when it's available. But with Euronurse, I got a lot of free contact hours to take care of all the requirements that I need. So hopefully it'll help you guys out. So let's take a look at what's coming on next week.
Dive deep into the evolving world of urothelial carcinoma treatment in this must-watch discussion hosted by Vic Senese of Euronurse. Join renowned experts Jason Hafron, MD, and Shilpa Gupta, MD, as they explore refining treatment strategies for advanced and metastatic urothelial carcinoma. This is a 1-hour CME credited program. Join us on February 7th at 9 a.m. Central Time to learn more.
Yeah, so again, next week we'll have another CME option for you available. Get your credits. Again, I thought I'd throw a few of these together because I know with renewals coming up, it's helpful to have those free contact hours. And we got some other great stuff happening later on in the month. We're going to be joined by the president of Sabuna to talk about what's new about being certified. You're not certified yet? Why aren't you? Get certified. So join us to learn more about that. And this is a great one. For those of you that have been with the show for a long time, you may remember Dr. John Lynn, who used to be with the show early on. He's going to be doing a presentation on terps. He's the terp king, and he's going to talk about that. So we'll have John Lynn back on the show. So be sure to join us every week to learn more on Euronurse, and we'll see everybody next week.
So here's to the mornings, the coffee, the monitor glow, to the wisdom he shares and the folks that he knows. Saturday is special when Vic's on the stream with 40 years of knowledge and a head full of dreams.